welcome. Very good afternoon to all of you. Welcome to the very first minimally invasive glaucoma surgery IC at AIOC. We are very pleased to have my speakers, Dr. Sunita Dubey, Dr. Swati Upadhyay, and unfortunately, Dr. Rashmi Krishnamurthy could not make it. She is unable to travel. We will try and cover all the procedures that are actually available in India and being done. These are nascent steps. We are crawling right now. We hope to take off, pretty soon. So before we start, I'd like to invite Dr. Baswati Sahu for her keynote address on minimally invasive glaucoma surgery, bridging the gap. Dr. Sahu, have you loaded?
Thank you, Dr. Vanita. At the outset, I'd like to thank the organizers, Dr. Pathak and Dr. Amit Porwal, for giving me an opportunity to share the stage with such eminent speakers. It's an honor to be present in this forum where I have my mentor, Dr. Sunita Dubey, sitting with me today. It's a very happy occasion for me. I'll be speaking on minimally invasive glaucoma surgery and providing an overview because we have such eminent speakers who will be talking on each and individual topics or devices. I have no financial disclosures. So to begin with, we have to understand what we know about glaucoma from the past. So we all know that glaucoma causes irreversible visual loss, and unfortunately, even today, it remains undiagnosed in most of the cases. Raised intraocular pressure has been thought to be the cause of glaucoma. The aim of treatment remains to preserve the residual vision, and the treatment kind of follows a step-ladder pattern where we have the medical management followed by laser, and then there is a gap where there's a long gap before one proceeds with a conventional surgery in the forms of trabeculectomy or tubes. So has anything changed in present? Sure, it has. So we have better diagnostic modalities, which leads us for an early diagnosis. So we should be asking the question, why still glaucoma remains undiagnosed in so many people, and it's still considered as the silent thief of sight? Well, the raised intraocular pressure no longer remains the causative agent, as we all know. It is a risk factor which is modifiable, and that's why it is so important. The aim of treatment still remains to preserve the residual vision, but providing a good quality of life. So why, we all know that nobody likes changes, so why the change? If we see this slide, the prevalence of glaucoma has increased over a decade, and hence the burden of glaucoma has increased over the society. A study published in BMJ has shown that the review time of the glaucoma patients have increased over a 1.5-fold. And hence, the rising cost of glaucoma management is affecting all the healthcare systems around the world. If we see the management of glaucoma, on one edge, we have the drug-based approach, and then there is the surgical approach, and then there is a long gap in between them. And that is where MIGS is the future. MIGS stands for minimally invasive glaucoma surgery. To be a MIGS procedure, there are certain criteria which needs to be fulfilled. It has to be minimally disruptive to the anatomical structures. It has to be conjunctival sparing. At least should cause moderate reduction of intraocular pressure, should have a high safety profile and a rapid recovery rate. Well, the indications are very simple. These days, it is indicated in combination with cataract surgery. Of course, in some countries, it still has been approved as a standalone procedure. It is usually, or the ideal candidates would be mild to moderate open-angle glaucomas and the ocular hypertensives. As we see the classification, this is a slide which was shown by Dr. Sunita in the morning. There are various areas which the MIGS work. So there were few of the procedures like the Zen and the InFocus, which involved the manipulation of conjunctiva, and such approaches are kept away as the MIGS technique. But we have the the Shemskinal enhancement procedures in the form of stents, wherein the eye stents and the hydras are there. Then we have the excision procedures in the form of trabecular and the GAT. Then we have the suprachoroidal devices as the CIPUS, and the ciliary body, the one which approaches the ciliary body is the endoscopic cyclophotocoagulation. I'll be mostly covering the eye stent because I know my other speakers are going to cover on the other procedures. So when the eye stent came in, it came in as an L-shaped approach, which was the initial eye stent. And then we moved on to the eye stent inject, which came as two devices in two stents in one devices. But it was narrow. And then what we have now is the one which is shown on the right-hand side, and that is the eye stent inject W. W stands for the wide flange which we see, and it was easy to manipulate. There are future eye stents coming up when we have the eye stent infinite, which has 3 stents in the single device, and then this tubular structure is the eye stent supra, which is again a suprachoroidal device. So there are ample number of studies now to prove the efficacy of eye stent, and this meta-analysis kinds of sums it up. Will not go into the details, but this is what has shown that eye stents is definitely proven to be effective as a standalone procedures along with cataract, and more the number of eye stents, greater the pressure reduction has been seen. So let's take a real-time example of an ideal case. So this is a 75 years old lady, myopia, pseudoexfoliation, a pressure of 28 on Travetan and Timolol. We can see on the right eye there is a superior arcuate defect there with some inferior retinal nerve fiber loss. Now this patient underwent an eye stent injection. So this is the surgical video. Video. Yeah. Yeah. It's not working here. हाँ उसी में वो कर रहे हैं. It's there. So I can say, as Dr. Harsh Kumar was saying in the morning, all we need to do as our practice is an intraoperative gonioscopic, and that is what is important. The initial challenge while doing an eye stent is just the patient positioning. As we know, we have to shift the head of the patient 30 degrees away from us, and the microscope almost 30 degrees towards us. So the positioning initial is a bit challenging, and that kind of position gives us an over-the-hill view of the gonioscopy. And once we identify the trabecular meshwork, it's very easy. We have to create a dimple there, and we can see here already there is one eye stent already positioned, a little oozing of blood, which is an indication that the stent is at the perfect position. So we can see the 2 stents over there at 3 clock hours of each other. This is another patient who has undergone eye stent, and we can see both the eye stent here at, again, 3 o'clock hours position from each other, and this patient did quite well with post-operative pressure of 15 and doing quite well actually. So the implantation depth, what we have to take, if you can see this in this picture, here this is a slightly superficial as compared to this. So this is a superficial implantation. In the other video, if you see, when you compare these two, this appears to be a bit deeper. Doesn't make much of a difference because these days the devices, we have 2 stents. So if one is positioned properly, it actually works quite well. The ideal distance, what has been mentioned, is 3 to 4 clock hours. But if we get a bit of a trabecular pigmentation and we can place our stent or direct our stent at this position, this actually works quite well in controlling the intraocular pressure. Now, the hydrus is another stent which is a collapsible semicircular stent which is placed in the trabecular, within the trabecular meshwork, and there has been various studies where they have compared the eye stent, and the compare studies showed It's a 12-month study which showed that the compare group or the high-risk group had a reduced medication use as compared to the iStent group. The Horizon study again showed that 73% of the high-risk patients remained medication-free at 5 years as compared to 48%, which in the cataract-only arm. So the trabecular excision procedures, the first among the group is the trabectome, wherein we use a microelectrode to avulse the trabecular meshwork, and Dr. Sunita will be talking in detail, so we will not go into the detail of this procedure. Then another excision procedure is the Cahook dual blade, which achieves a near complete removal of trabecular meshwork. Gonioscopy-assisted trabeculotomy is a procedure wherein we can either use a microcatheter or use a Prolene suture to create a trabeculotomy, and that helps in reducing the pressure. Now, the CYPUS device till date was the only suprachoroidal device. It initially showed very good results, but unfortunately, the 5-year data showed greater endothelial loss, and this was withdrawn by the company voluntarily. The endoscopic cyclophotocoagulation, and we'll be hearing soon from Dr. Vanita, I think she'll be covering in detail. It is a procedure wherein we use an endoscope to target the ciliary processes, and this is the only procedure which works by reducing the aqueous secretion, whereas the others work mostly by increasing the outflow. Now, when it comes to MIGS, the concerns today we have is the cost, and second is the efficacy. Now, there are various studies which are done mostly by the insurance people, and they have seen that the projected cost comparison of all these devices when compared with the medical management is proven to be cost effective. And when it comes to efficacy, the debate considering it is because most of the studies are comparing it with trabeculectomy. Now, we have to understand that MIGS is not a replacement of trabeculectomy. So if we are comparing MIGS with trabeculectomy, we are actually comparing apples with oranges. So there are very clear-cut indications for MIGS and clear-cut indications for trabeculectomy, where our target intraocular pressures is in the mid-teens. It is a mild to moderate glaucoma. The choice of surgery is MIGS. But where our target intraocular pressure is in the lower teens, probably we would like to move in for the trabeculectomy. As the discussion was going in the morning, yes, it is designed mostly for open-angle glaucoma, but people are now stretching their limits, and I myself have done iStents in a lot of angle closure patients who are doing quite well. So yes, the devices can be done in angle closure glaucoma patients. We have studies which have shown trabectome being done in failed trabeculectomy and tube implants, and it has been combined with the tube implants to avoid fenestration of the tubes for the temporary maintenance of the intraocular pressure, and it has been used in all kinds of phakic, pseudophakic, and aphakic eyes. So the phrase catch them early, which is very apt to glaucoma, I would say that not only catch them early, treat them early so that none of the patient progresses from this to this stage. And in this context, I think MIGS is the game changer ahead, and it is that light at the end of the tunnel which is going to bridge this gap. And for me, success would be that day, which is my futuristic thinking, that glaucoma should not be considered as an irreversible cause of blindness. We should be able to diagnose it much earlier and start the treatment much earlier, so that glaucoma should fall into in the category of reversible blindness as cataract. And we should all be able to provide that good quality of life for all of our patients which they deserve. And for all the wine lovers, you're most welcome to come and visit me in New Zealand. I am representing New Zealand from the Hawke's Bay region, which is considered the wine region of New Zealand. Thank you very much for your kind attention.
Thank you very much, Basudhi. That was indeed a comprehensive review of MIGS, what is available worldwide. Unfortunately, not everything is available here in India. So I now invite Dr. Sunita Dubey to talk about MIGS trabectome step by step.
So at the outset, I would like to thank Dr. Vanita for giving me this opportunity. After a very energetic talk by Dr. Baswati, I'll be talking on one of the devices which was introduced in India in 2019, and fortunately I was the first one to start this procedure, and I was forced into it, I would say, and that time I was not even aware of the MIGS procedure. So traditional surgeries like traps and tubes have been successfully employed for several decades, and we are getting very good results also, but sometimes we encounter sight-threatening complications. So MIGS, being conjunctival sparing mostly, avoid the complications and relative unpredictability of the conventional glaucoma surgery. So if you look at this management spectrum, MIGS were designed to bridge the gap between the medical or laser therapies and more invasive filtration surgeries in mild to moderate glaucomas. However, as has been mentioned by Baswati also, that they can even be performed in advanced glaucomas, and they definitely reduce the need for glaucoma medications. And they're especially useful when you are doing cataract surgery. So along with cataract surgeries, most of the MIGS surgeries can be combined. And if the patient can't use medications, if the patient is allergic or non-compliant, and in long run, they're more cost-effective than medications. So they can be classified on the physiological mechanisms. And in India, if you're talking about the Indian scenario, we have started doing these Shemskinal trabecular bypass surgeries, like iStent, iStent inject, and most of the trabeculotomy surgeries, GAT, trabectome, Cahoog blade also now is available. And now we have a very cheap procedure in India, the bang procedure, which is done with 25 gauge needle. So the mechanism is to target the site of maximal resistance, and thereby increasing the outflow through the conventional pathway, which is mostly defective in patients with glaucoma. So we know the juxtacanaliculaar site is the site of maximum resistance, and we have maximal concentration of collector channels nasally, and that is why most of these procedures are performed in the nasal quadrant. So now coming to trabectome, it was the first MIGS procedure, and has been approved in 2006, and it's a stand-alone device and utilizes a plasma-mediated ablation system, and it achieves complete removal of diseased trabecular meshwork and inner wall of Shemskinal. And since it's an excisional goniotomy, wherein you are stripping off a piece of trabecular meshwork and the inner wall of Shemskinal, so it minimizes the signs of chances of scarring and reocclusion of collector channels. As you can see, the edges of the trabecular meshwork are far apart, and there is very less chance of rescarring. And other advantage is that it has irrigation and aspiration incorporated into the device. So when you're learning procedure, the AC is well maintained, and it pressurizes the anterior chamber and thereby manages the blood reflux. So you won't see any blood while you are doing the trabectome surgery. And the foot switch guides the electrosurgical tip, and it also protects the adjacent tissue. So this is the insulated foot plate with this sleeve, which protects the angle. And they also have Trabex, which is compatible with the phaco. So if you just buy a probe, you can attach it to any phaco machine. So trabectome can be used, goniotomy with trabectome can be done in any type of glaucoma. And mostly when you begin, you do in open angle glaucoma, but it is very effective in pseudo-exfoliation pigmentary glaucoma, in pediatric glaucoma, and in narrow angle glaucoma also, as we were discussing in the morning, and it can be performed especially after PI. So gonioscopy is very important. We have been emphasizing again and again that if you want to start mixed procedure, you have to learn intraoperative gonioscopy. And after doing phaco, you just put the direct gonio lens onto the cornea and try to visualize the angle. And angle is best visualized when you tilt the microscope towards surgeon and rotate the patient's head away from the surgeon. It maximizes your gonioscopic view of the angle. So it is very, very important that you do at least 25, 30, or every day whenever you are doing phaco, you practice this intraoperative gonioscopy with a direct lens. Just this animation video, how it's being done. So 1.8 millimeter clear corneal incision is made, and you put the high viscosity viscoelastic onto the cornea and then insert the tip inside the anterior chamber and approach the angle. As you can see here, the irrigation is coming from the probe as well as the aspiration, and this is the active and return electrode which will deliver the plasma energy, and then you just introduce it, engage the trabecular meshwork and ablate it first on one side and then on the other side. So I'll be showing in my video that if you are in the right plane, then you do it very smoothly without any resistance. So these procedures are generally combined with cataract surgery, and I prefer to do it before cataract surgery. So you have to first visualize the angle and then give an incision and introduce this probe with the irrigation on, and it deepens the anterior chamber. Even if you're not able to visualize it very clearly before, after introduction of the probe, you can visualize the angle and then just ablate the angle on one side. And this is basically ablating the trabecular meshwork and the inner wall of Shemskinal. So this white line, what you're seeing, is the outer wall of Shemskinal. So, and as you keep rotating the gonio prism, you can target 140 to 160 degrees of angle, and then you perform your phaco after the procedure. And after these procedures, it is important to see whether your procedure is working or not, and the best way to visualize it, to inject fluid, as I'll be showing here. And when you inject the fluid, you can see this blanching of vessels, and this ensures that you have made a connection between the anterior chamber and the collector channels which are there. So this is a sure shot sign that your procedure has worked. So after any goniotomy or goniectomy procedures, I think it's important to do this exercise. Since it's a very old procedure, there are n numbers of articles, and this is the article which was done after first decade of trabectome surgery, and there were almost 5,000 cases which were followed up to 90 months, and these were the survivability criteria, and the results showed that there's 66% success achieved in trabectome alone after 90 months, and 85% if you combine it with phaco and phaco. So, and the meta-analysis concluded that it lowers the intraocular pressure by 36% while decreasing the number of medications by less than 1. So it looks quite promising. And there are various studies, as has been mentioned by Dr. Baswati also, that the trabectome, there are studies wherein people have done trabectome after failed trabeculectomy and even after Barwelt and AGV implants. And the reason is that the collector channels do not completely atrophy. So if you have done your trabeculectomy superiorly, you still have that trabecular meshwork on the nasal side which you can ablate or treat. So we have, now it's going to be published, we have our data which we have followed up to 1.5 to 2 years of 58 patients, and I have included all types of glaucomas, and I have even included severe glaucomas because initially when I started, I included most of the glaucomas, and I combined the trabectome with phaco in 42% and trabectome alone in 58%. And this is the result. So without phaco, the mean IOP with medication was 24.4, and which got reduced to 14.6 at the end of 1 year. And with phaco, the mean IOP was 16.6, which reduced to 13.4 at the end of 1 year. So at all time points, lower IOP values were obtained in phaco group. However, the percent reduction was significantly greater in non-phaco group owing to higher baseline IOP. So there are studies which suggest that if the baseline IOP is high, the pressure reduction would be more. And there was definite reduction in the number of medications. And this is the survival analysis of our group, wherein the patients undergoing phacotrabectome had a survival of 88% at 1 year, and phaco alone and trabectome alone had a survival of 67. So overall survival was 76%. And just 2-3 cases. So it works very well in pseudoexfoliation and pigmentary glaucoma. This was one of my patients who had undergone phacotrabeculectomy in one eye, and the other eye was 24 on 2 AGMs, and she had cataract also. So I did phacotrabectome, and this was the visual fields in the right and the left eye, and there was remarkable reduction in the intraocular pressure, and the number of medications she was completely off the medication. We are very scared of doing trabeculectomy in patients with high myopia. So this is a very good procedure. Any kind of goniotomy is good for patients who are young and myopes because there are chances of hypotony. So this is a patient with pigmentary glaucoma, the young myope, and the one eye underwent trabeculectomy, and you can see there was a very good bleb, but he had persistent chronic hypotony. So I did the trabectome for the left eye, and he had very good cleft, and the pressure control was very good. And last but not the least is that it can be used in congenital glaucoma, and this is one of my patients whom I operated bilateral trab plus trab. One eye did well, whereas the other eye progressed with vascularized bleb and corneal edema and an increase in the eggshell length. And I even did needling for this patient, but then I decided to do goniotomy with trabectome, and you can see here there's high iris insertion, which is common in patients with congenital glaucoma, and I did goniotomy, and you see there's very nice opening of the angle, and you can see this outer wall of Shemskinal. You see this white line, and the patient now is perfectly all right. The child is all right. So to end, I think you need to choose appropriate candidates, especially when you are starting your MIGS. Learning intraoperative gonioscopy need not be emphasized again, because this is a must. With proper visualization of angle, just navigate the angle with any kind of instrument, the Sinsky yoke, so that you get the hang of trabecular meshwork, proper wound construction, ablating the TM along the arc without any resistance. If you face any resistance in goniotomy procedures, please come out and do it again, and proper post-operative management. So I think that's it. Thank you.
Thank you very much, Sunita. That was wonderful. We will take questions at the end. Please hang on. We'll answer all your queries. Can we start, please? Right, so Bhaswati, we are actually doing eye stents here now for the last 9 months. And yes, that was the very first eye stent that was implanted in India in September last year. So I have 9 months follow-up for this particular patient, and I'll give you the history of that patient. You will be amazed. So I'm going to talk about eye stent and eye stent inject. We have not, Glaucas has not introduced W yet for us. And then, of course, Infinite is still in the pipeline, and iStent Supra is also undergoing clinical trials at the moment. So they have reclassified it as a trabecular micro bypass system. These are my disclosures. So just to recap, I'm sure you've gone through a lot of presentations throughout this conference, but basically MIGS was something that was, the term was coined in 2012. I have done my fellowship with Dr. Ike Ahmed in Toronto in Canada. He was one of the key individuals instrumental not only in coining this term, I think in collaboration with Glaukos, but also looking into the research and development of many, many more. So basically, these surgeries cause minimal trauma to the target tissue. They definitely reduce your operating time. They do have modest efficacy. You cannot compare it with trabeculectomy. It is not here to replace trabeculectomy, and I quite agree with Baswati there. It has a very high safety profile, and there is rapid recovery. It's almost like phaco. Patient recovers vision within the week. In most cases, in a few cases of GAT, they may have a little bit more hyphema and may require an AC wash. So basically, conjunctiva and sclera are spared. There is no bleb formation, so there is no worry about hypotony or bleb-related problems. It acts by bypassing the trabecular meshwork, and it reduces dependence on anti-glaucoma medication. So these are the key factors that one has to remember about iStents. Now, iStents are one of the smallest devices known to mankind. When iStent first came out, and this is now called G1, Generation 1, this was just about 1 millimeter in length and 0.3 millimeter in height, and of course has both FDA and CE approval. But the most important thing I feel is that about all these surgeries is that it spares the conjunctiva. So in future, ever you require trabeculectomy, it is never contraindicated. Then the next generation, G2, that came through is the iStent Inject. Now this has become 1/3 the size of an iStent G1, and its height is 0.3. Its width is about less than 0.3. So then came the iStent W, where the height and the width are the same. So that's the modification, so that there is no over-implantation. So this is a modification, of course. And it comes preloaded with 2 devices. There is no right or left stent, unlike the G1 devices. So here we are. These two, I will show you ex vivo, how they work. iStent works by a maneuver which is parallel to your trabecular meshwork. So you insert it parallel to your trabecular meshwork. It's actually pretty easy to do if you know how to do intraoperative gonioscopy. It actually gives you quite a bit of a high, quite a bit of a buzz. That's iStent. And iStent Inject is basically a perpendicular injection. So you create a dimple onto the trabecular meshwork and inject and release. That's it. It's as simple as that. Actual procedure does not even take 5 seconds, believe me. So what is the difference between iStent and iStent Inject? There are 2 stents with iStent Inject. Both come preloaded. And it is relatively easier implantation because it removes the manual variable. There is no right or left. So with the iStent G1, I prefer the left orientation. I don't like the right orientation because that is backhand. So, these are small issues. Here's a video. You will see that you have to visualize the angle at high magnification, introduce your device, increase the magnification again after having decreased it, and implant your device in the trabecular meshwork, and that is exactly how long it takes. 5 seconds, unedited video. When you see blood, regurgitating, that's an excellent sign because it means you're in the correct position. Here you can see that the retention arches are well embedded inside the Shemskinal, and you have a snorkel which is proud of the surface of the trabecular meshwork. Unlike the eye stent, which, sorry, the next one now. Unlike the eye stent which which should be almost flush with the surface of the trabecular meshwork. Here we are, two being implanted. The first one, here, slight dimple of the trabecular meshwork, and then you inject and you withdraw in the same plane so that you don't disturb. You tap it a little bit and you make sure that it is in position. You don't see a regurgitation there, I do notice that. I like to withdraw it out of the eye, reposition myself, and then go back in, and this video I borrowed from a co-fellow from Toronto, and he prefers to do the same. So here we are, the second one also, little bit eccentric, I felt. Nonetheless, it's now flush with the trabecular meshwork. So how does it work? It creates a micro bypass through the trabecular meshwork, providing a direct channel between the Shemskinal and the collector channels. Everyone knows that it's the juxtacanalicular meshwork that creates the maximum resistance. So it bypasses that. Huang et al. Did a really excellent work by doing anterior segment angiography of the aqueous veins to show pre and post eye stent angiography. Before the procedure, you can see that there's very little flow through the aqueous veins, collector channels and aqueous veins. But after placement of two devices, you can see that the channels which appeared to be dormant have opened up. So it has the potential to re-establish flow in previously dormant outflow channels. Also, it increases the facility to lower resistance to outflow. Now, this is also another very elegant work by Cindy Bala et al., much before Alex Huang came up with their angiographic one, where they have found that with one eye stent, you double the outflow facility, and if you put two, you actually make it 5 times. So it actually works. Here you can see that there is dilatation noted around the eye stent inject head. This was again an ex vivo study, it wasn't an in vivo study. So what are the indications? They are mild to moderate, primary open angle glaucoma. This is the mandated, but as you know, we all are trying to do in various different types of glaucoma. However, one needs to classify the glaucomas on visual fields. They are mild to moderate only on visual fields. It could be open angle, pseudoexfoliative, whatever. Also, you can do it in phakic patients. You don't necessarily have to combine eye stents with cataract surgery, but you can, of course, do. You can do it in pseudophakic patients. You can do it in patients who have difficulty taking medication, who have side effects or complications to these, or, as we all know, are poorly compliant patients. I will not go into details about all the studies that have been published because, again, going through the various presentations, I found that many people have talked about many, many studies, but I will talk about this systematic analysis, meta-analysis, which has shown, a long-term one, which has shown a very consistent decrease of about 30% in intraocular pressure from baseline, and also reduction of medication, and that over 60 months, only 2.6% of the eyes of all the studies that were included required filtration surgery after that. So what are the complications that you can expect? Not a long list at all. In fact, I had to scratch my head to find some. Iris endothelial touch, well, that is something will decrease with experience. Over or under implantation, you have maneuvers that are available to correct these. There can be stent malposition. You may have to withdraw and reposition. Sometimes you can have occlusion. which you can observe or can consider doing a YAG laser. Sometimes you have hyphema, but I have not come across it so far, and if it happens, it's usually transient and self-resolving. Late post-op, need for glaucoma filtration surgery is only 4%. Compare this, and we keep saying this, compare this with the long list of complications that can happen with trabeculectomy or even with drainage surgery. And I feel one of the least talked about complication of trabeculectomy is bleb failure. It is a complication of the surgery. And one has to look at it, these are all failed blebs, failing or failed blebs, and blebs that are predisposed to infection, lifetime of infection. Depends on which literature you're reading, but basically it can vary from 0.4 to 6.9%. Here's a patient who, fairly young, 55-year-old, who had pressures running in mid-40s, for whom I had to do a trabeculectomy because at that time, iStent was not available in India. Lo and behold, he works in an oil field in Duliajan, Assam, off the coast. And he came back to me with blebitis. He was fortunate enough to recover not only vision, but also his filtration without any medication, but not every patient is that lucky. Complications in glaucoma drainage devices, again, those that are common for all subconjunctival filtrations, and there are certain unique ones that are common to all types of GDD. You have tube exposure, plate exposure, you have tube endothelial touch, you have tube block, you name it, you have it. So I just want to present to you a real world experience very early, in our country for related to iStents that have been done by these 4 surgeons. Follow-up, as you know, because it's very, very early, it's only 4 weeks. They were all combined with cataract surgery, all open-angle glaucoma, and they all had high medication burden, either intolerance and or allergy. So we started with a pressure of almost 20, anti-glaucoma medication of 3.8, and we ended up with, we're still studying it, 14.4 and 1.8 medication. That translates to about 27% reduction in IOP and 52% reduction in medication, which was all statistically significant. I present to you the first case of iStent that was done in this country. He was a 61-year-old gentleman who had actually already undergone trabeculectomy. And not just trabeculectomy, he had undergone needling 3 times. Post-surgeries, slowly, over a period of time, 5 years, he needed 5 topical medications to control his IOP, and he subsequently developed severe intolerance to these medications. His preoperative IOP was 22 millimeter mercury in the right eye on 5 anti-glaucoma medication, and because these medications were withdrawn, the offending medications were withdrawn in the left eye, his pressure had shot up to 29. And he was mild to moderate in both eyes, although he was progressing in the right eye. So this is his intolerance. You can see the changes in the conjunctiva. And a phaco iStent was done for him in September 2021, and the left eye was done in January 2022. And post-operatively, now 9 months in the right eye, 6 months in the left, almost. We have visual acuity of 6.6 N6 and intraocular pressure of 17 on 2 anti-glaucoma medications in the right eye and 18 without any medications in the left eye. So this is what he looked after anti-glaucoma medications were taken off, but have a look now. This is the middle one is when anti-glaucoma medications were taken off, and this is how he looks now without any medications or only minimal medications in the right eye. So this was the video of the very first iStent done in this country. I had a few challenges in terms of my video equipment, but I think the majority of it we have managed to capture. Again, you have to have an en-face view of the trabecular meshwork, and that is where your good technique of intraoperative gonioscopy is extremely important. and you slide it in as a parallel action, and you release. After this, unfortunately, my video conked off. But there you are. The view always should be clear, view of the angle. So I leave you with a few tips for performing a successful MIGS. Please remember, preoperatively, you have to counsel with respect to the patient expectations. You cannot tell them that you're going to have fantastic pressures, and we're going to stop all medications. That may be possible, but it's not always possible. So you have to counsel with respect to their expectations. Stop antiplatelet drugs, very, very important. You do not want hyphema, any kind of bleeding when you're doing the surgery. There should be a conscious, pre-planned, pre-procedure practice of intraoperative gonioscopy in phaco cases. In your routine cataract surgery, you can change the position of the patient and the microscope, take an intraoperative gonioscope, and just do it. It just takes 2 to 5 minutes to complete, and it will give you greater confidence when you actually take up the surgery. You have to have awareness of different types of intraoperative gonio lenses, and you have to be able to visualize the angle under high magnification. And I would suggest that you use a Sinskey and go right up to the trabecular meshwork, get a feel of the trabecular meshwork. So just showing this in a few steps. This is Schwann-Jacob, and this has been widely used in not just in India, worldwide. I have it because I did my pediatric goniotomies with it, but I find that the view with Schwann-Jacob, now that there are many more lenses available, is not that brilliant. As you can see, in that particular case, of course, there might be a problem with the capture also, but even here, when there is no problem, there is problem with capture, you can see the trabecular meshwork far clearer with this lens. This is an iPrism S. It's a disposable lens, and this one is a very different type of lens. It's called iPrism SX. It's vertical, and you do not need to hold it. It stays put on the cornea. So your left hand is actually free. When your left hand is free, then there is no chance of you causing corneal indentation and loss of clarity. That is very important. And what you see with these in terms of brightness and in terms of clarity is way, way better than Schwann-Jacob. That's my personal opinion. People might differ. Then positioning of the patient and the surgeon. Surgeon, it is better to sit temporal because you want to target the inferonasal quadrant first. If you're doing an eye stent inject, you can reposition yourself. Microscope positioning, about 30-35 degrees. Patient positioning, about 30-35 degrees. So here we are. You need to measure where you are. So microscope towards you. This was my training before my first case. And so you make sure that the microscope is turned towards you and the patient away from you, about 30-35 degrees. And create phaco wounds that are slightly anterior to the limbus. You do not want bleeding from peripheral vessels all the time. That also reduces your view. So I would suggest you go into clear cornea a little bit, as much as possible. And as you can see here, there is no bleeding when that wound is made. Then, like I said, practice of intraoperative gonioscopy in phaco cases under high magnification with Sinskey to the trabecular meshwork. This case is that of an angle closure who opened up after laser peripheral iridotomy. And I'm just using a Sinskey hook to show you all the minute synecdoche that had formed for this particular patient. So to summarize, MIGS are usually ab interno, minimally traumatic, safe procedures which preserve the conjunctiva. It fills the void between medical management and more invasive traditional surgery. So medical management, till they are managed, it's good. But if they are mild to moderate and they are not controlled, then you can move on to MIGS procedures rather than trabeculectomy. So it is bridging. It's bridging that gap, which is exactly what Bhaswati was talking about. iStent and iStent Inject are two of the smallest devices known to mankind and helps to bypass the trabecular resistance and improve facility of outflow. Mostly indicated in OAG, that is what it has been mandated for, mild to moderate glaucomas. In initial footprint in India is a little varied. We have used it in advanced glaucomas also. In controlled and uncontrolled, moderate, mild, moderate, and one or two severe cases in our series, it has reduced pressure to about 27%, medication 50%. And inevitably, cost may be a limiting factor. Thank you very much. Yeah, we will take questions at the end, like I said, and I invite Dr. Swati Upadhyay now to talk about GAT.
Good afternoon, everyone. I'll be talking about suture GAT. My topic is suture GAT demystified. So most of the things we have touched up, but I will be talking exclusively on GAT. So it's a gonioscopy-assisted transluminal trabeculotomy. So we are opening of the trabecular meshwork, the Shemskinal. So it's an otomy, not an ectomy. GAT is the brainchild of Dr. Davinder Grover and Dr. Ronald Feldman at Glaucoma Associates of Texas, Dallas. It cannulates 360 degrees of the Shemskinal using a 5-0 Prolene suture, but initially it was done using eye-track microcatheter, which is not yet approved in India. So we do it with the 5-0 Prolene suture, and it creates a 360 degree trabeculotomy. So this is the video which I wanted to show. 1 minute. टाइमिंग्स निकाल दीजिए, मैं बताती हूँ आपको, 1 सेकेंड. So I'm blunting the tip of the 5-0 Prolene suture. I normally blunt both the sides. Suppose it's one side it's not moving, so I'll just change that side. And this is just to show that it should be just mushroom and it should not be a very bulbous mushroom. We make a paracentesis for the suture entry. And then we make a main incision, through which we are going to introduce the microsurgical forceps. Fill the anterior chamber with high viscosity Helon GV or Orogel. Then we introduce the blunted tip of the suture, the blunted suture through the side port, directing it towards the nasal angle. We put a dollop of OVD on top of the cornea. Then we tilt the patient's head away from us 30 degrees or 35 degrees, and then we tilt the microscope towards us 35 degrees, as already told by Dr. Vanita ma'am and Dr. Sunita ma'am. We place, this is an eye prism OA, that is open axis, which has got a notch through which we can introduce the instruments. This is a 25 gauge MVR blade, and we are going to make an initial goniotomy, just 1 clock hour goniotomy, just to open up 1 clock hour of Shemskinal. So this is the posterior wall of Shemskinal, which you can see the white part. The initial goniotomy is very important. It should be just 1 clock hour, so that when you introduce the suture into the Shemskinal, you can see that your suture is going behind. It's a blue tinge. The blue color of the Prolene helps you to see the suture behind the trabecular meshwork. With gentle strokes, you keep on pushing it or just thrusting it or threading it inside the Shemskinal. Don't let your AC become shallow. Keep on augmenting OVD or Orogel or Helon GV. As Dr. Vanita said, that you should have a very good en-face view of the angle. So this is the indirect goniolens, which is a single mirror goniolens, to confirm the suture presence in the Shemskinal. So I'll just pause it here, and I'll show you that this is the Shemskinal. This is the blue color suture seen in the Shemskinal. So if you see the scleral spur below that suture, that means your suture is in the right place, and you can keep on continuing pushing the suture. So see, till here. And it's a single mirror gonio lens, so this is a disposable one. But if you have a gold mirror single mirror, just keep it autoclaved, ETO'd, and just keep it. Why it is going So after confirming the suture presence, just keep pushing the suture into the Shemskinal till it appears from the opposite side. At 180 degrees, we will encounter some resistance, which is a good sign that your suture is still in the Shemskinal. It is turning 180 degrees, so you'll have a little bit of resistance over there. Now you can see the suture has appeared from the opposite side, and you hold it above the suture which you have introduced in the first place. So once you catch hold of it above the suture which you had initially introduced, just take a McPherson forceps and pull it from outside. So it will create a 360 degrees trabeculotomy. So coming on to the preoperative tips for suture gad, patient selection is very important. So these are the initial angles you should start with, where you can see the trabecular meshwork and a beautiful scleral spur below. If you have angles like this, where there is a pigmentation, patchy pigmentation, where you are not sure whether it is the trabecular meshwork you are entering or where is the scleral spur, so to avoid taking these angles in the starting. Mild to moderate POAGs are the ideal cases. You can have pseudoexhalation glaucoma, pigmentary glaucoma, and also OHT patients. So before you start, intraoperative gonioscopy is very, very important, as Dr. Sunita and Dr. Vanita have emphasized. Turn the patient head 35 degrees away from you, tilt the microscope 35 degrees towards you. And also very important for all mixed procedure is to avoid bleeding from the Shemskinal. You should have a reverse Trendelenburg position. You should have the head end of the table elevated, so that the head is above the heart, so that you don't have, with the initial goniotomy itself, your Shemskinal, the collector channels will start bleeding into the anterior chamber. So to avoid that, you should keep the head above the heart. Secondly, you should have heavy high density viscoelastic with you, so that you can, as soon as the bleeding starts, you can tamponade it, and you should do a very good preoperative counseling. These are two videos of intraoperative gonioscopy. As madam has emphasized, that if after you do a phaco case, please turn the patient head away and tilt the microscope. You should have a tiltable microscope for that. Also practice the foot switch of the microscope, because once both the hands are engaged, you cannot magnify, you cannot focus up, focus down. So you should have a very good command of the microscope foot pedal also. So this is how you see the angle. Intraoperative problems can be, you can have bleeding from the Shemskinal, you can have a non-advancing suture, you can have a false passage, and you can have shallowing of the anterior chamber. So what are the tips? To reduce bleeding from the Shemskinal, as I already said, that you should have the head above the heart, lift the head end of the operating table, and it will reduce reflux. Use higher density viscoelastic. What to do about how to avoid false passage? You should use intracameral pilocarpine first of all, after finishing your phaco, or if you are doing a GAD alone, then it is good. If you are doing phaco with GAD, then do a phaco beforehand, so that you don't have to, you don't compromise the pupil. And after you complete phaco, you constrict the pupil, make it myos, then you can see the angle structures properly. You should have a proper understanding of the angle structures. The image on the right hand side is shown that the suture on the right hand side is a very big tip. This is a very big mushroom, and on the left hand side is just blunted mushroom. So you should not have very thick mushroom, because then it will create a false passage. Limited initial goniotomy is very important. Don't open up the whole of nasal angle which you are seeing through the lens, and confirm the suture presence in the Shemskinal using the indirect gonio lens. If you have a non-advancing suture, first pre-measure the suture. So how do we pre-measure the suture? We just make a loop of the proline around the eye, and we just kink at a place okay, just get a rough estimate that, okay, how this much suture I will be needing inside the eye. Normally it is around 4.5 centimeters which you will be needing. So just mark it, so that while pushing, if the kink appears in the anterior chamber, you will be knowing that I have used enough of my suture and still it has not appeared from the other side. So you can be aware, okay, I have to take, my suture is going somewhere different place. Confirm the suture presence using an indirect gonio lens. We can try a twin site GAD. So if the suture is not advancing from one direction, you can make an inferior paracentesis and go anti-clockwise direction. So what we are doing first is we are going anti-clockwise. If your clockwise is not going, do a anti-clockwise is not going, do a clockwise. If you have a shallowing of anterior chamber, so use a heavy high density viscoelastic and just place the gonio lens gently on top of the cornea so that you don't have folds, as you can see in the lower image. Post-operative complications, yes, hyphema is the most common complication after GAD, and you ask the patient to sleep on the side of surgery, not on the opposite side, which we normally ask the patient to sleep after a cataract surgery. So what will happen if the patient sleeps on the side of surgery? All the hyphema which occurs will accumulate on the temporal side. So our nasal channels which we have opened will not get occluded by the blood clot. So it can vary from a microhyphema to a layered hyphema, and but all the hyphemas in my experience, they have cleared up within 3 days to 7 days. So it's not something to get worried, but the patient will get definitely worried because vision will drop from 612 to hand movements or 1/60. So proper counseling is a very, very important thing for GAT. So what if you have hyphema? Counsel well, discuss with the patient as well as one caregiver. Form the AC in the end with some Helon GV. You can either fill 20% or 30% depending upon the reflex which you are getting intraoperatively. Leave Helon GV. It will not cause rise in the IOP, as we normally are scared that we are going to increase the pressure. It doesn't. Hyphemas are self-resolving between first week. You can use pilocarpine 2% and also brimonidine for first 7 days. What if you have a false passage and if you land up with a choroidal detachment? Then we have to manage it conservatively using systemic and topical steroids. Again, counseling is the main key, and patients from the doctor side and from the patient side is important, and these CDs usually will resolve within 2 weeks. So this is the post-operative cleft which Dr. Sunita was also showing us, a white line which you see. It is the posterior wall of the Shemskinal which we see, and it is mostly in GAD. In my series, mostly I could see in the nasal angle and the superior angle. I think that the trabecular meshwork leaflets close on the inferior side because of gravity, or I don't know, but mostly clefts are seen remaining on the nasal and the superior side. So these are the clefts which we see. Post-operative gonioscopy will reveal little bit of PAS, but these are very small, narrow base PAS, and we don't convert the open angle into an angle closure glaucoma, which some people have believe that, okay, we are converting open angles into closed angle. It is not the way, because whatever you have opened up and cleaved away, it will not grow back. It will be bared only. And sometimes you can see some blood reflex from the Shemskinal or some blood clots when you press the gonio while doing post-operatively. You can see the reflex from the on the right hand side. You can see the gonio mirror image. So our experience, we did more than 30 eyes, but I have included only 23 eyes for analysis because the patients didn't come for follow-up after 1 week or 15 days like that. So in our series, we had 63 years as the mean age, and 23:7 males and females. We had 20 patients of POAG and PXF glaucoma 6, 3 NTG patients and 1 angle recession glaucoma with a mean follow-up of 317 days. Right eye were 13 and left eye was 16. So these are the baseline characteristics. I could get a 360-degree GAT in 23 eyes out of the 30 ones which I'm telling you. So 270 degrees in 5 eyes, and only 180 degrees I could achieve in 2 eyes. So I had to do twin site GAT. Preoperative IOP was 24.4. Anti-glaucoma medication, active ingredients were 1.2, visual acuity was 1.3. So in terms of IOP, we have achieved 91.3% success rates with the newer definitions, not the less than 21 millimeters of mercury. We are taking into account more than 20% reduction from the baseline as the success criteria. So we have 91.3% success rate. Failure was in one, in which the patient had high IOP in spite of a 360-degree GAT even at 1 year follow-up. So we don't know, something else is also going on in that patient, or steroid response. We excluded all the causes, but still. So the mean IOP for the 23 eyes which completed the success, which fitted the success criteria were like 24.8, which fall down to 11.8 plus minus 4.3, which was statistically significant. In terms of vision improvement, yes, the vision dropped on POD1 because of the hyphema. It went down to 1.3. But at the end of 1 year, it was statistically significant. The logmar improved from 1.2 to 0.3. Out of the 30 eyes, 22 eyes had microhyphema or layered hyphema in one form or the other. So you should be mentally prepared that yes, you might have hyphema. Anti-glaucoma medication active ingredients reduced from 1.3 to 0.22 plus minus 0.7, and that was also statistically significant. I had intraoperative complications which I showed you: shallow AC and twin side GAT done, profuse bleeding intraoperatively, false passage in 180-degree suture GAT in 2 patients. So this is the most important part, that no hyphema was seen only in 7 eyes, microhyphema in 8, layered hyphema in 10, shallow AC in 1, and choroidal detachment in 1 patient. So I would like to say that suture GAT combined with cataract surgery provided 91.3% success rates in terms of both IOP and vision, and hyphema being the most common complication. More than 90% of the eyes had resolution of hyphema within the first week. So my take-home messages will be: GAT is suitable for mild to moderate open-angle glaucoma cases. You should select widely open-angle glaucoma, open angles on gonioscopy for the first initial cases. Do a very good pre-op counseling. Practice intraop gonioscopy on routine phaco cases, along with practicing of the microscope foot pedal. Don't make a large initial goniotomy. Just 1 clock hour is enough. Feed the suture in the Shemskinal. Don't push it. Then otherwise you will have a false passage. Head above the heart is mandatory for all mixed procedures, and use liberal high molecular weight OVD. Use indirect gonio lens to confirm suture position, and be patient and perseverant. Thank you. I would like to thank my mentor, Dr. Venkatesh, and my teacher of GAT, Dr. Devinder Grover. Because of them only I'm standing here. Thank you.
Thank you very much, Swati. That was really good. I will move on to मुझे ऑडियो लगेगा इस presentation में ऑडियो लगेगा. I'm going to talk about endocyclophotocoagulation, and I have been doing this for many years now. I actually learned it during my fellowship in Toronto. I did not get the opportunity to do it in India. When I first came back for many years, I got it for a short time. I did a couple of studies at that time, and I was so convinced that I have now acquired it again. So as usual, these are my disclosures. So endoscopic cyclophotocoagulation uses a near-infrared diode laser. It's the original mix. It's ab interno. It's best combined with cataract surgery. It does not disturb the conjunctiva at all. It was first described by Urim in 1992, and it was mostly used in open angles and refractory glaucomas. But the advantage is that it can be used irrespective of angle status, because direct visualization of the ciliary body does not bring the angle into play. Here you can see there is mild pseudo-exfoliation that you can see, and that is why you can see the zonules. Otherwise, the zonules are also not visible. And this is a case where there was much more pseudo-exfoliation, so you can see the zonules much clearer. Therefore, the indication is varied. You can use it in any kind of glaucoma you want. The only 2 glaucomas I don't use it in is neovascular and uveitic. Otherwise, I use it in all glaucomas. And usually, the amount of power that you first start with is only 1/4 that of the transscleral delivery. I mean, this is a massive advantage. Of course, there's a disadvantage. It requires a sterile environment, and it is difficult in phakic eyes. I have not tried it in phakic eyes yet. You can also use it as a standalone procedure. So your entry can either be corneal or pars plana. If you're doing pars plana, then you need a limited vitrectomy. And the complications list, brace yourself, I have not seen anything beyond this. Fibrin, yes, especially if you're getting pops, which if you make a conscious effort to reduce, you will not get it. CME, yes, but that can also happen due to cataract. We don't know. And there are some mild pupillary abnormalities that I have noted, and plus minus hyphema. I won't even call it hyphema. Sometimes you get a few blood clots. So what do I mean by endocycloplasty, and what is endocyclophotocoagulation? So when you paint the entire body of the ciliary process, it's called cyclophotocoagulation. If you only aim the tip of the ciliary process, then it's called endocycloplasty. So you can see this one has been done. It shows a whitening and it shows a reduction in height compared to its neighbor. That means that this particular ciliary process has been lasered. So your orientation is very important. I always like to put the iris on top. And therefore, when you have your iris on top, you have your capsule, anterior capsule at the bottom. And so, inevitably, there is ciliary process in between. Lasering the tip helps to open up the angle, and I'll show you evidence of that. So here we are before I have performed any kind of laser, and here you can see once laser has been performed, the height is decreased compared to its neighbor. So you know there is shrinkage, there is shortening, and there is whitening. So I have done a few studies, and these were the two studies I did when I first had access to it, where I have done it as a retrospective study in primary angle closure glaucoma, and I was very happy to note that not only was there significant reduction in intraocular pressure and anti-glaucoma medication, but there was a 75% complete success. Patients were off glaucoma medications for 18 months. Complications were mostly transient. Like I have told you, the list is very, very short. 2 eyes failed and needed trabeculectomy. So I pitted phacoendocycloplasty with phacotrab. And this was mostly in moderate or advanced glaucoma, because trab I wouldn't do in mild glaucoma. So it was a randomized controlled trial. The efficacy, the intraocular pressure reduction was comparable to phacotrab. There was significant IOP and AGM reduction with a complete success yet again of 75% in each group. So what separated the two? The complications and the interventions related to those complications. So you may as well ask, why not phaco alone? Why phaco ECP? So to address that question, I did a retrospective study, and a randomized control trial is underway. This publication is pending. You can see that with the VFI, generally speaking, it's mild to moderate. It's not very advanced glaucoma, and the preoperative characteristics were very well matched. Intraocular pressure, anti-glaucoma medication was reduced much more in the phacoendocycloplasty group, where recovery of vision was good in both. So the percentage reduction of IOP as well as the percentage reduction of anti-glaucoma medication was double that of the phaco alone group. Not only this, the complete success, yet again, I get it in mid-70s. So now I have 3 studies to prove that I can achieve complete success in angle closure glaucoma with endocycloplasty, phacoendocycloplasty, at the rate of at least 75%. And of course, this was statistically significant. Again, what separated the two? Although the number of complications, rate of complications was not statistically significant, but aqueous misdirection, especially intraoperative aqueous misdirection in angle closure glaucoma was much higher. And so the interventions related to that was much higher. Here is one case, phaco alone, she had recurrent angle closure. On the left side, you can see prior to surgery, the AC became deep post-operatively, but only after I did an IZHV for this lady. I had to enlarge her peripheral iridotomy, and I did a zonulohyaloidovitrectomy with a primary posterior capsulectomy. And since then, she is not only deep, but well controlled without medication. So I do phacoendocycloplasty in acute angle closure also. I have a collection of 6 eyes, and all of them are well controlled. I'll show you a brief video. This is, first is on presentation, shallow AC. Second is after PI, and third is after phaco ECP. So I'll just show you a brief video about Phacoendocycloplastic resolution of acute on chronic primary angle closure glaucoma.
Disclosures nil relevant. Primary angle closure glaucoma is a chronic and largely asymptomatic disease unless the presentation is late. However, this may occasionally be intercepted by a symptomatic acute presentation in the presence of glaucomatous disc changes. Patients complain of pain and present with shallow AC and very high intraocular pressure, and there may be variable degree of ciliary congestion, corneal edema, glaucom flecken, and sphincter ischemia. All eyes in this series underwent laser peripheral iridotomy first. When this failed to resolve the issue, then the surgical route was taken. Mannitol injection was administered preoperatively wherever indicated. After phaco surgery and IOL placement in the bag, a 20-gauge endoscope was introduced into the AC to visualize the angle. Here in this case, it appeared to be almost completely closed even after phaco. Following this, the endoscope was introduced into the sulcus and the ciliary processes were visualized. Delivery of the laser was under direct vision and it was aimed at the tail of the ciliary process, the end point of whitening and shrinkage of the ciliary body posteriorly away from the iris. Approximately 28 to 32 processes were treated, covering 180 to 210 degrees. Laser energy was determined by shrinkage of the ciliary process and varied between 250 to 500 milliwatts, duration being constant at 2 seconds. POPs were strictly avoided, and when encountered, it warranted a reduction in the power. At the end of the procedure, the endoscope is reintroduced into the AC, and in this case, the angle seems to have opened up, albeit with heavy pigmentation. Viscoelastic is then washed thoroughly. In another example, angle is closed post-phaco and only a clump of pigment is visible anterior to Schwalb's line, but it opens up after endocycloplasty. This is a case where intraoperative gonioscopy was done. Angle was closed prior to cataract surgery and after it. However, post-endocycloplasty, it opened up inferiorly, barring 1 clock hour of peripheral anterior synecdoche on iris. In this series, 6 eyes of 5 patients were included. All were females, mean age 52, mean axial length 22.5, mean AC depth 2.3, mean lens thickness 5.0. Mean BFI was 31.2%, mean peripheral anterior synecdoche on gonioscopy was 3.4 quads. All preoperative baseline parameters of visual acuity, intraocular pressure, anti-glaucoma medication were vastly improved post-operatively, and none of the eyes had any serious sight-threatening complications. To conclude, in this series, phacoendocycloplasty led to satisfactory resolution of acute on chronic primary angle closure glaucoma.
Okay, so key points from the studies involving phacoendocycloplasty is that complete success is about 75%. It is superior to phaco alone, non-inferior to trab. No sight-threatening complications were seen. Remember, angle closure eyes, especially with multiple mechanisms, are at increased risk of aqueous misdirection. So if you're doing only phaco, you are risking the complication. Endocycloplasty, on the other hand, will deepen the AC, stabilize the depth, as well as control the intraocular pressure. So it avoids intra or post-operative aqueous misdirection. So just to summarize, ECP is the original MIGS described in the 1990s. You can combine it with cataract surgery, do it in standalone pseudophakics, aphakics. It's an ab interno procedure, spares the conjunctiva, very versatile as that it can be used irrespective of angle status, can be used in mild, moderate, and severe disease, is targeted compared to the transscleral delivery of diode. Laser power is less than 1/4 that of TSCPC. And reduction in anti-glaucoma medication, I keep repeating, helps to overcome several issues. The biggest of all is continued risk of ocular surface disease, adherence and compliance issues, quality of life issues, and of course, we disregard this all the time. It's the cost of the anti-glaucoma medication also. These two, the procedures too, unfortunately, can have, cost factor. Next presentation, please. And I just want, in the last segment, because Dr. Rashmi is not there with us, I just want to show you some videos of Kahoot dual blade. Next one, please. Usme de rahe hain? हाँ, कर दीजिए. No, I don't want this. Right. So basically, it's a single-use blade, stainless steel blade. It incises and removes a strip of trabecular meshwork. So it's excisional in nature. It de-roofs the Shemskinal. So you have seen many other procedures that de-roof the Shemskinal. So you can compare it to the trabectome, even with GAT. And the same effect as Kahoot dual blade, or KDB, can be achieved with a bent needle. I put this just a few days ago that it has not been granted regulatory approval in India yet, but apparently it has been now, just 3 days ago. So it is available in India, but at quite a substantive cost. So after the tissue is engaged by the tapered tip of the KDP, it moves up the angled ramp up to the two parallel blades. With advancement of the blade, you get a ribbon of TM, and this is aspirated from the anterior chamber. Now, this is some case I did of steroid-induced cataract and glaucoma in a 21-year-old who wasn't controlled on 3 drugs. He did not have a very clear trabecular meshwork. You can see it is very, very pigmented, and the scleral spur seems to have merged into the trabecular meshwork. Nonetheless, I did get a good excision with the Kahoot dual blade, and this boy is doing extremely well. You can see the trabecular meshwork being aspirated there. A slightly clearer version, Rashmi had a video which had slightly clearer view, so you can have a look here. She does it slightly differently. She goes in the center, comes to, does a straight-handed approach, and then goes to the side of it and covers it, covers the whole area. You can see the remnants of the trabecular meshwork there, and that can be easily aspirated. Now, the same effect can be achieved with a bent needle, like I was telling you. Bending it is very easy. Unlike doing a capsulotomy, you go the other side. You do it anteriorly. And when you do that, you can see that the tip more or less resembles that of a Kahoot dual blade. And the procedure is like any MIGS procedure. As you will see here, you just glide, and as soon as you see blood, you know that you're in the Shemskinal. You have to clear that blood. You can see the white area that is being exposed. That's basically the outer wall of the Shemskinal. And what I do is I start at a point, go counterclockwise, and then go back to that same point and go clockwise after that. Here in this case, you will see it being cleared out, the trabecular meshwork being aspirated out as well. So you can see the white zone The white zone tells you that your Shemskinal has been unroofed. Sorry. And I just wanted to show you how it is being, the trabecular meshwork is being aspirated. Just, yeah. Under gonioscopic view, you can see the trabecular meshwork there. Can you see the strip being aspirated away? And that's what I do. I do it under gonioscopic view. Okay, so thank you very much. If you have any questions.
Dr. Vanita, now they have come up with the KDB Glide, which is 90 microns as opposed to the earlier one, which was 250 microns.
250, yeah.
So it is finer.
Yeah. Any questions?
I have a question to Swati. So you said that you will fill after GAT the antechamber with like 30% with Helon GV. So what is the rationale of 30%?
Ma'am, nothing. If I see more reflex during the surgery, I can fill it more also. I can do it half AC fill also, 50% fill. So
okay, so
yeah, so it
because
depends
I thought
upon
specifically.
no,
So it depends
nothing
on
like
the
that. Depends
amount
upon
of bleeding.
intraoperatively how much bleeding you feel.
And you just check the pressure, how much is it.
Yes.
So you want to keep the pressure high.
higher side, just to use it as a tamponade.
Yeah. So can't you use air or saline or
But
BSS?
normally air goes to the superior side, superior part, and it doesn't actually tamponade the nasal angle, which we actually having the maximum collector channels.
Okay.
So if we use Helon GV or Orogel and we ask the patient to sleep on the side of surgery, so everything will
So
go
it
and
tamponates
tamponate the
the-
nasal part.
So I
That's-
think both the things are important. If you're filling it 30%, you ask the patient to sleep on the
On the
side
yeah,
of surgery.
in
also.
any case, we
Yeah.
ask the patient
On
to
the
sleep.
nasal side.
All the
basically.
on
mix.
nasal side.
No,
And
but
it-
we don't see so much hyphema with
No, not with
with the
iStent
others.
or
No,
KDB.
or
yeah.
bang
Not with
or
trabectome
we don't
also.
we don't
No,
see.
Trabectome, nothing at all.
No,
Yeah.
nothing at
Yeah.
all.
iStent might leak sometimes.
Yeah, trabectome is
But not this
electrocautery,
next
so it's
stage.
So it's-
cauterizing
yeah.
also.
It's ablating and as well as
Yeah.
aspirating at the same time.
Yeah.
So
One question. Comparing GAT and iStent, what are your views? Any specific indications differentiating the two? And I can't understand why an iStent, which is just so much microns on 2 points, is achieving IOP reduction, whereas in GAT we are doing 360 degrees of opening up of the trabecular meshwork. And
it is also working.
yeah, that's what. Why just 2 points and then why 360 degree IOP reduction is almost similar in a
That
few
is
studies.
actually an excellent question. And so the question arises, do we really need 360 degree
360 degrees,
trabeculotomy? Isn't it? Especially when I am also getting quite good results with bang alone. Just the video you saw, the last one where you're seeing the aspirate, that lady was a one-eyed patient. She was an angle closure who opened up after PI. So I said, we'll do bang for you rather than anything else. She's 6 visions, 12 pressure without any medication. So yes, you can achieve. I feel that you can achieve with much lesser unroofing. You may not need, even she's saying that, when you post-operatively, when you examine the gonioscopically, you see the rest of the angle probably closing up, because in GAT, you're only ripping it apart. You're not excising it. Yeah, there are various ways. GAT, of course, is especially suture GAT is doable, is cost-effective, so to speak. But I feel it is a little bit more than just minimally invasive. It is not that minimally invasive. And also the other thing, when I started doing MIGS, I did a lot of literature search and things like that. So when deep sclerectomy was first, I don't know whether you've heard of deep sclerectomy, was first described, there was a group in South Africa and there was a group in Switzerland. Okay, they got good results, but worldwide the results were not as good. Similarly, Davinder Grover has good results. Worldwide, not so.
Our
good.
results are better than his somehow. So I would like you to understand, if you have a patient, mild to moderate glaucoma on 1 medication, on 2 medication, on 4 medications. So iStent, bang, GAT. This is how I deal with it.
Yeah, can I answer that?
Yes.
Yeah, so to answer your question, so with iStent, we are targeting the collector channels. We are not seeing anything. We are just presuming that the inferonasal part is the area where the collector, if we put an iStent there, the inferonasal, and it is just over the collector channels. So when there is direct access to the collector channels, the results are really good.
The
And we
proximity to the collector channels
yes.
is the
So
differentiating
how
part.
much proximate you are to the collector channels depends upon your results with iStents. And currently that's the reason why these devices, they're putting more and more devices, more and more stents in the single device. In the generation 1 came with a single, the generation 2 came with 2 devices. Now they're going for the iStent Infinite because they said more the
Dr. Vanita, I also
devices, more the control of pressure, because you are targeting more and more collector channels. Vis-a-vis GAT, where you're opening up the roof
I
entire.
think as she's rightly mentioned, because iStent has been advised in mild to moderate glaucoma, and we are assuming that the collector channels are still open.
Yeah.
When the disease advances, the disease otherwise in mild to moderate, it is just affecting the trabecular meshwork, the sclerosis of the trabecular meshwork. But with advancement of the disease, it is going towards the collector channels also. So that is why all these procedures do not work that well in very advanced glaucoma when the collector channels have collapsed or Shemskinal has collapsed, okay?
Right.
So that is why it's very important, as I had shown, you have to see the patency of the collector channels by injecting fluid. If you're getting that fluid wave, that means your collector channels are patent.
Right.
And if you do get in very advanced glaucoma 360 degrees, you're assuming that somewhere some collector channels are still functional. And that is why I had shown in my presentation also that even if you have done TRAB, after that if you do one of these procedures, it can still work because all the collector channels have not closed. Or
Yeah, so
not
actually
sclerosed.
speaking, we
Yeah.
don't have an answer for that.
It's a
Okay?
blind thing actually.
Yeah,
you know.
Correct.
we do
Sometimes it
not
works,
have
sometimes.
a clear understanding
Yeah.
as of the moment, but we know it works.
Right.
There are 900,000 eye stents that have been implanted worldwide. Okay,
No, I'm
so
not
no,
doubting
I'm just telling you. So it is working. That's why it's being implanted.
Correct.
Okay, it wouldn't be it wouldn't have a shelf life if it
True.
weren't working. So that is one. Secondly, yes, even my first patient of iStent already had a trab, so we had bypassed the trabecular meshwork, but yet when we put an iStent, it functioned somehow. And he was on medication for so long, and
Right.
5 medications.
Right.
So, the understanding, the full understanding is not there. Yes, there are, I showed you a couple of studies, how our understanding of placement of such small devices are actually, so that is why it is said that when you start, you should target mild to moderate, nothing more. And you should not, patients should not be on anti-glaucoma medications for very long. And the target IOP, your ultimate target IOP should be between 16 and 20.
Right.
Don't be overambitious.
And there are some studies which have shown that even 3 or 4 clock hours of the cleft, if you see that and if that is open and functional, it will work.
Right, ma'am.
So
Yeah,
if
same for
So I
that
did my
also.
first-
directing towards
did my
patent
first-
collector channels, it will work, even
Right.
the little amount
So
of.
with that knowledge, ma'am, should we do GAT in the inferior angle first? Should we start
No,
opening there?
nasal.
You can do
all the
collector
bits
on the
channels are
nasal
maximum
side only.
nasally, inferonasally.
You can start
So you are
only
anyway
nasally.
making the incision temporally,
Right.
and you're targeting the nasal
Inferonasal.
collector channels.
And you won't like to have a hyphae minor patient who's monocular with macular split,
True.
even if he is on 4 medications. So for
Hemi
mix,
GAT, I think.
and 180
hemi
degrees
GAT,
also works.
180 degrees.
So
So I
you
did my
have to
first
titrate
GAT
according
this
to
Monday.
patients. Huh?
I did my first GAT this Monday,
Oh,
and
nice.
excellent presentation, ma'am. All the panelists
Thank
and
you.
all. It was really helpful.
Achha,
Thank
you
you.
are already doing GAT.
I just started doing
Oh, so
this
that's
week.
Good,
That's
good.
great.
My
Well
second
done.
case is
How's the patient?
Good. 11 IOP on the first
Yeah.
post-operative day, 6 very small hyphema. I could do almost 270-degree GAT.
Yeah, so initially when I also
Yeah.
did my first, you just try to do 180 degree or 270, and later on then I realized that I could have done 360 degrees also,
Right.
because it was going very freely without any resistance.
And
But
I use the iPrism SX,
Yeah.
It's
the
wonderful.
disposable one.
Yeah.
Ma'am, how many
Or you
times
can
can
use
we
it.
ETO it?
You can ETO it and or plasma
Till
it
you
and
have the
use it-
visibility,
use it for-
okay, you can.
In India,
You got to
we
check
eat
for
you everything.
scratches. I have a question for Baswati. I'm sorry. When you said you did eye stents in angle closure, were you talking about angle closures that opened up after PI?
Yeah.
Or were you doing a goniosynucleasis with it?
No,
and
no,
Opening
it's-
up the angle and then doing it?
So I did after, in all cases of angle closure, after PI. And whenever I do, so with eye stents, we can use it before the cataract surgery or after the cataract surgery. So when it is an angle closure, then I usually do it after the cataract surgery, because that kind of helps me. So my idea is, after the PI, if it is a primary angle closure suspect, you are just doing the cataract. You're not doing anything. If the patient is a primary angle closure post-PI requiring more than 2 medications, I do an eye stent with the cataract. If it is a primary angle closure requiring less than 2 medication, I still do away with the cataract. I never, because once you remove it, if it's a big cataract, the pressure goes down. If it is a primary angle closure glaucoma, those are the patients where if I can see the trabecular meshwork, I can do. Now, if sometimes what happens, there are synechias, patchy synechias, so I don't do a goniosynucleasis or anything. I just I have a case where I have put the stents in between the synechia. There's just a patch of synechia. I have not
Yeah.
touched that, put
Yeah.
2 on either side, and that
I suppose
works
you can
quite
do
well.
that, but when you have the whole quadrant shut, then
Yeah.
then it becomes
So
an
yeah,
issue.
that's why
Then
you
it
do the
becomes an issue.
after the PI. I usually do the gonioscopy
absolutely,
before
absolutely.
taking the
Yeah.
patient.
And
That's
after
right.
taking out cataract, most of the angles open in.
Yeah, but even after taking out the cataract, if there is a synechial angle closure
Yeah,
nasally,
then
it's
it-
But
Then
I
it
just
becomes-
demonstrated to you that is not the case.
Yeah.
Endoscopic view has shown that it actually
yeah.
does not
In some
does not open does
but
not open
in
up
that
in.
angle, you obviously can't put stents.
Yeah. I just wanted to make a couple of points about post-operative management of these cases. We have to remember that to understand, especially I feel where devices are concerned, so where eye stent is concerned, you need to know how much eye stent is reducing the pressure. So you need to actually stop all your anti-glaucoma medications from day one. And your washout period, especially if you are given a PG analog before that, is up to 4 weeks, remember. So your IOP reduction related to your eye stent will never show up. How much it has come down because of the eye stent unless you have stopped all. Okay, that's one. Second is, unlike trabeculectomy and tube, where you're creating a bypass and trabecular meshwork no longer comes into play, your drainage through your trabecular meshwork with all these procedures is still going on, other than GAT, because in GAT you're removing it totally. So steroid response is seen much more in these patients, open angle patients. So please remember, I always make sure that the other eye pressure is also done. Why? Because fellow eye raised pressure is a clear-cut diagnosis that you've got a steroid response. So please keep these two things in mind when you're managing post-operatively.
But I think indications for tube implants are completely different.
No,
we
I'm
do
not
need-
talking about that.
No. People like, trabeculectomy, we can still postpone for the later date. But in our setting or setup, we are not doing tube implants in primary glaucomas. They're
No,
mostly
not
very
at all.
secondary.
I'm not talking
For the
about-
audience, I think that is very important that the indications of tube implants are completely different, and none of the mixed procedure is going to replace tube implants. The
No,
indications
we're
we
not
will-
talking about replacement. We're talking about these two procedures bypassing the trabecular meshwork
Yeah.
totally. Whereas MIGs don't. They still, your trabecular meshwork is still in play. So For what? You can use if you're worried that there is going to be synechial formation, especially if you have a lot of hyphema. That's why you want to avoid hyphema. Unfortunately, as you heard, about 70-75% get hyphema in
I
GAT.
think Western population, they do give pilocarpine.
Pilocarpine,
after
yes.
these
So,
procedures.
So for eye stent, no need. For bang, also
need.
I don't think so, sir, because it doesn't bleed. Trabectome also no. Only for GAT, yes.
But remember that you get a lot of more inflammation with
inflammation.
pilocarpine also. So one has to then step up the steroids. If stepping up the steroids is pushing up the pressure, then you have to. So it's like a cycle. No, not known. I was worried about one. I felt only 2 retention. There are 3 retention arches. Only 2 retention arches were in. I was a little worried it might move. It hasn't so far. And I was reassured by the parent company that it's unlikely to happen. So it hasn't happened.
Sir, intraoperatively it can get missed, but if it get missed, then you cannot find it. So we have to be very, very particular where we are going, where we are touching, when we are injecting it.
No, you
Otherwise
can
it's
always
safe.
retrieve it. If
Yes.
it is not
But it
gone,
is
if,
not
if
it's
you're
lost,
easy
then you
yeah.
cannot find it.
You can retrieve it, you can reload it, and you can reinsert. But if, say, for instance, you on table you thought you have got a good position, and post-operatively when you're doing a gonio, at really high magnification, you're seeing only 2 retention arches in, then, that is what happened to one of my cases, but, that has not moved.
Yeah, it
That's for
stays
sure.
there. It
Yeah,
stays there.
it stays there.
Spontaneous hyphema after exercise. No, it doesn't happen, sir. Huh. Bang.
That is,
So, but sir,
he is looking at the cost.
Hmm.
He is looking at the cost. But I will tell you one thing. Since the point of the cost has come up, let me tell you one thing. We are all using intraocular lens implants. We are all using multifocals. 1 lakh, 2 lakhs. Are the patients, when you're offering it to the patients are not saying no. If they can afford it, they want it. So I feel you should not be deciding whether the patient will say yes or no. Patient needs to have the option. It's up to them to accept or not accept. Of course, you have to offer it to the correct patient. The indication has to be there. You cannot indiscriminately offer it. So if you have a mild to moderate open angle glaucoma, please offer it to that patient. Nowadays, I do not do cataract surgery in glaucoma patients without offering mix. It's up to them to accept it. And another point I'll make here, since you talked about cost, I have done all my eye stents under insurance cover, and they have been fully reimbursed. So please try it. Okay? You can take. It's up to you. It's definitely up to you. So my way of approaching it is, if a patient has insurance, I will tell them about the procedures available. If they have insurance and if they like the idea of an eye stent, believe me, the ones who have cardiac problems, who have had stent, they like the idea of stents. They understand the idea of stents. So they go for it, and so far they've all been reimbursed. There is no forcing here. Patients want it, we will do it. Patient doesn't want it, we won't do it. And when you pick up the topic of Dr. Tanuj Dada, he's also written an editorial where he has asked, do we need to do 360-degree trabeculotomy? So I don't know if 3 months ago, GAT, yes, 360. Yeah, the bang.
Yeah, that is one.
He's actually written an editorial. I think about a year ago
I think
or
he's
so.
against 360 degrees.
Yes.
Because later on the drugs will also not act, the Rho kinase inhibitors and other drugs.
No,
which
it's not
act
just,
on-
we are
So ma'am, the drugs act
taking
because
away
we are
the
not removing the trabecular mesh. It's still there. The leaflets close. I have seen the gonioscopies. So yes, sir. Yes, sir.
so it will not remain open completely.
Yes, ma'am. So what I have seen is superior
what
and
is
nasal
the
angle remain open, temporal and inferior
So
get
you
closed
do
again.
that much only then.
Yeah.
That's my
Yeah, that-
point.
the
You
thing
don't
is-
need to do 360
The thing
degrees.
is 180
That
degrees
is, I think,
cannulation
that-
only you
this
can
is
do.
this is exactly what I am trying to get to.
Correct, ma'am.
That you are doing a GAT for 360 degrees, but we don't need it.
You just do
do,
hemi-
do it
The
limited.
the problem is you
Hemi-gat.
cannot retrieve a suture at 180 degrees. The problem is that.
You
So,
can,
Ma'am,
Swati.
ma'am,
you can just pull
Swati,
the
you
other
can.
hand.
I have done it.
180 degrees you cannot,
Yes,
madam.
I have done it in a
I had shown
congenital
in the
glaucoma
module.
case who had had a
that
trab and
is-
trab. So they already had a
From the
trabeculotomy
opposite
done.
end you cannot take.
separate.
From the same entry point you have, you
opposite
can
end
take.
you
No,
cannot
you
take
move
the
position.
suture off.
No, ma'am.
Move
180
your-
degrees it will be on the temporal side where you are sitting. So you cannot change that position.
No, you don't necessarily have to sit temporal. That's the thing. When you're doing it under
Anyway, we
GA,
will
how
have
where do you sit for
modifications
it?
of GAT
Yeah, there are
later.
modifications. There are modifications. I have taken it out.
Yeah.
Then we can take.
Yeah. Superotemporal.
Yes, sir.
and- Yes, yes.
Yes, we know that. We are
Yeah, that
quite-
is
yeah.
why I know. And what about is there any
No, but the idea is that you're ripping. You're ripping. No, I have no problems in taking off one quadrant or slightly more than one quadrant or less than two quadrants. But I do have a little bit of reservations now that FACO Bang is working so well, FACO KDB is working so well. Why to do 360 degrees? That's my point. Of course. You take the lead. You take the lead, I will participate. Yeah, sure, okay.
I
Fine.
think these people have very extensive experience in GAT, and I think we are awaiting your paper
Yeah.
on GAT.
Right, so any further questions? After some really very lively Yes,
I have.
I have.
I have one patient who landed up with angle closure somehow because I had intraop hypot on intraoperatively also had shallow AC which continued postoperatively. Then I had to do a PI. Ultimately, patient was lost to follow, but with good vision and good pressure control. But still, angles were closed.
So there was a
So one
patient
patient.
who came to me having lost vision in an eye where GAT was done. That was converted to 360-degree angle closure. That clinched the issue where GAT was concerned. Anyway, with this, let
I
me
think
close
let's
the
close
session. I am really thankful to my speakers. You have heard firsthand, there's no theoretical knowledge here. You have seen practically how MIGS can be done. It is mission possible in our country. Thank you very much.